Imagine for a moment the incredible vulnerability and, well, the boundless potential of a newborn foal. Freshly on its feet, all wobbly legs and innocent eyes, it's a truly miraculous sight. But what if beneath that picture of vibrant nascent life, there's a silent, unseen battle happening, a hidden danger that can undermine their health before they even have a chance to truly thrive? Today, we're taking a deep dive into exactly that kind of hidden challenge: neonatal equine gastric ulcer syndrome. It's a condition that might sound complex, but it's surprisingly common and incredibly important for understanding foal health.
Yeah, absolutely. And our mission today is really to extract the crucial insights from detailed veterinary sources on this. Think of it as getting a shortcut to understanding what these ulcers are, why they happen, how they're diagnosed, and what can be done about them.
Right.
We'll explore the hows and whys so you can quickly grasp this multifaceted challenge. What's truly fascinating here is how much these very specific stomach ulcers can reveal about a foal's overall systemic health.
And that's precisely what we're here to do: cut through the noise and get to those critical insights. We're drawing from specialist-level veterinary references for this one, giving you a comprehensive, in-depth look at this specific health challenge in foals fast. So let's unpack this. When we talk about neonatal equine gastric ulcers, what exactly are we dealing with?
Well, at its core, we're talking about sores or damage to the stomach lining. These can show up in the upper non-glandular part, the lower glandular part, or even right on that critical dividing line between the two, the margo plicatus.
Okay, so it's not just one type of damage in one spot, and that idea of damage to the lining sounds like a fundamental problem. What's the core imbalance that causes these ulcers to form in the first place?
It really boils down to a fundamental imbalance. On one side, you have aggressive factors that actively damage the stomach lining, things like, hydrochloric acid, pepsin, bile acid.
The harsh stuff.
Exactly. And on the other side, you have the protective factors that shield it. So healthy blood flow to the stomach, the mucus bicarbonate layer, natural prostaglandins, even proper gastric motility. When those aggressive forces overwhelm the protective ones, well, that's when the ulcers take hold.
So it really boils down to that delicate balance within the stomach. That's a powerful way to frame it. Our sources highlight two main types of ulcers here. What are they, and what's the fundamental difference in how they develop?
Right. So the first type, squamous ulcers, are located in the upper non-glandular part of the stomach. Their primary driver is prolonged exposure to gastric acids. And what's particularly interesting is how this exposure can be exacerbated by things you might not expect.
Like what?
Well, like delayed gastric emptying, prolonged recumbency, basically, lying down for extended periods, and even infrequent nursing.
Infrequent nursing. That feels counterintuitive for a newborn. How does that contribute?
Yeah, it does seem odd, but milk actually acts as a natural buffer for gastric acid. So less frequent milk intake means less buffering and therefore more acid exposure for that delicate lining.
Oh, okay.
And here's another fascinating detail. The normal shedding of the squamous epithelium, it's called desquamation. It occurs in about 80% of foals up to 40 days of age. And this normal physiological process can also be related to these ulcers.
Wow, that's a crucial piece of information. Normal foal development actually intersecting with ulcer formation. Now, you mentioned the second type, glandular ulcers, are often considered more clinically significant. What makes them different?
Yes, these are often more serious. The glandular mucosa, the lower part, is normally protected by a pretty robust mucus bicarbonate layer. For glandular ulcers, the primary causes are a disruption of mucosal blood flow and a decrease in the secretion of that protective mucus and bicarbonate.
Okay.
And this is where it connects to more serious systemic issues like septic shock and hypovolemia, which lead to hypoperfusion. Basically, reduced oxygen delivery to the mucosa, making it incredibly vulnerable.
Right, so it's less about direct acid attack and more about the lining losing its defenses due to bigger health problems. So beyond these main types, can these ulcers spread or create problems elsewhere in the digestive system? Maybe at the stomach's exit or even further down?
They certainly can. Ulcers can also occur right at the stomach's outlet, the pylorus, or in the first part of the small intestine, the proximal duodenum. And when they do, they can then lead to secondary squamous gastric and even esophageal ulcers.
How does that happen?
It's usually because these distal ulcers cause delayed gastric emptying and reflux, so stomach contents back up, prolonging acid exposure in those other areas.
Okay, that makes sense. It's like a chain reaction. So if we understand this a basic battle between aggressive and protective forces within the foal, what are the specific triggers that push that delicate balance over the edge? What really puts them at risk?
Well, building on those two main mechanisms, increased acid exposure and mucosal blood flow disruption, we see specific risk factors emerge. For squamous ulcers, prolonged fasting is a significant one. Reduced feed means less saliva.
Less buffering.
It's exactly less buffering, and you get continuous acid exposure.
Mm.
Also, decreased gastric motility and delayed gastric emptying. They slow down digestion, increasing the time acid spends in contact with the stomach lining.
And for the more severe glandular ulcers, what are the primary culprits there?
For glandular ulcers, it's really all about that disruption of mucosal blood flow. Conditions like hypovolemia, reduced blood volume, and shock directly compromise that vital blood flow. Even stress, can trigger physiological responses that impair mucosal blood flow, making the foal more susceptible.
And there's one major actionable insight our sources really highlight for owners, isn't there? The use of NSAIDs, non-steroidal anti-inflammatory drugs.
Oh, absolutely. Hands down, it's understanding the profound and often immediate impact of NSAIDs. They are a major concern. They contribute to ulcers in multiple ways, decreasing mucosal blood flow, inhibiting bicarbonate secretion, and stimulating gastric acid secretion by blocking prostaglandin synthesis.
Wow, a triple whammy.
Pretty much. This is the primary lever owners have to help prevent these issues. Understanding that NSAIDs, while powerful, demand absolute veterinary oversight for foals. It's also worth noting that elevated levels of endogenous corticosteroids, say from stress or illness, can have similar effects to NSAIDs, also decreasing mucosal blood flow and inhibiting bicarbonate.
That's a clear and incredibly important piece of advice for anyone caring for foals. Now, how common are these ulcers actually, and what are the signs a foal might be showing? What stands out to you here?
The prevalence is actually quite surprising, and honestly, it's a key insight from our sources. Reported prevalence in foals varies pretty widely, from maybe 25% up to 57%. But here's the real kicker.
Yeah.
Endoscopic surveys of clinically normal foals, these are foals 2 to 85 days old who don't appear sick at all, revealed that 50% had squamous ulcers, and somewhere between 4 and 9% had glandular ulcers.
50%. In apparently healthy foals.
50%. It really highlights how pervasive they are, often hiding in plain sight. And there's also no reported breed or sex predilection, which means basically any foal is potentially at risk.
So we're not just talking about sick foals here, are we? This isn't just a complication. It's like a silent epidemic in otherwise healthy newborns. But for the ones that do show signs, it's not a single presentation, is it? Our sources mention distinct ways these ulcers can manifest.
Absolutely. It's not a one-size-fits-all scenario. Our sources outline 4 distinct clinical syndromes. The first, and probably the most common, are silent or subclinical ulcers.
The hidden ones.
Exactly. These are particularly prevalent in foals under about 4 months of age. They are often found, incidentally, maybe during a post-mortem examination, or in foals that are sick with something else entirely. Crucially, as the name suggests, clinical signs are completely absent. They might even heal spontaneously without anyone knowing they were there.
So they're just quietly there doing their thing. That's a bit unsettling. What about when they do show signs?
Yeah, then we move into active or clinical ulcers. These primarily involve the squamous mucosa, that upper part. The signs here are more overt. You might see depression, anorexia, poor appetite, bruxism.
Teeth grinding.
Right, teeth grinding, teetalism, which is excessive salivation, maybe dorsal recumbency lying on their back, and of course, colic signs.
Okay. And then there's the really terrifying one, the perforating ulcers.
Indeed. The third type is perforating ulcers with diffuse peritonitis. These are uncommon, thankfully, but when they occur, they are highly severe and often fatal. They most frequently occur in the squamous mucosa. The really tragic part is that clinical signs are usually absent until just before rupture.
Oh, wow.
Yeah, so their severity is poorly predicted just by looking with an endoscope. Once ruptured, foals rapidly show progressive evidence of endotoxemia. They might develop abdominal distension, exhibit severe colic. The prognosis is, well, it's grave.
That's a horrifying scenario, especially with such little warning. What's the final syndrome mentioned?
The fourth syndrome involves pyloric strictures, secondary to gastric outflow obstruction. These are also uncommon, most frequently seen in foals, maybe 3 to 5 months old. Signs include that teeth grinding again, excessive salivation, and importantly, postprandial colic after eating.
After eating, that's specific.
Very. You might also see aspiration pneumonia because of chronic reflux, dehydration, and a very specific electrolyte imbalance. Systemic hypochloremic alkalosis. That happens because they lose hydrochloric acid from chronic reflux or vomiting attempts.
So many different ways these can manifest. Beyond these specific syndromes, what are some of the general historical findings or physical exam signs a vet might pick up on?
Well, vets might ask about a history of poor growth, maybe a rough hair coat, a pot-bellied appearance, or any prior illnesses like diarrhea, colic, lethargy, anorexia. On the physical exam, the most commonly observed signs often include depression, intermittent nursing, colic, sometimes diarrhea, and those classic signs like the teeth grinding and excessive salivation we mentioned.
Okay. With such varied signs, some subtle, some severe, how do vets definitively figure out what's going on? How do they move from suspicion to a definitive diagnosis? Given how broad those signs can be, what's the diagnostic journey like?
Yeah, that's a great question. The first step is often ruling out other conditions because, as you said, many of these signs overlap with other things that cause colic. We're talking about things like small intestinal intussusception, maybe pyloric stenosis or enterocolitis. Lots of possibilities.
And lab tests. Do blood tests or urinalysis usually give clear answers?
Not usually, no. CBC, biochemistry, and urinalysis values are often normal. They might reveal a stress leukogram, changes related to stress, or maybe anemia if there's been significant blood loss from the ulcers. Other tests like fecal or gastric occult blood tests might suggest bleeding, but it's critical to remember these tests are neither sensitive nor specific for gastric ulcers or their severity. They're definitely not the smoking gun.
So labs aren't definitive. What about imaging? Can that help narrow it down?
Imaging can certainly play a role. Abdominal radiographs, X-rays might help rule out other causes of colic. Barium contrast radiographs are useful if they suspect a gastric outflow obstruction, like that pyloric stricture we talked about. And abdominal ultrasonography can be performed to look at intestinal wall thickness, check for ileus lack of gut movement, or detect peritoneal effusion, fluid in the abdomen, if a perforation is suspected.
Okay, so imaging helps piece things together, but given the limitations of other tools, how do vets ultimately confirm a diagnosis of gastric ulcers in foals?
Right. The definitive diagnosis comes from gastroscopy. It allows direct visualization, actually looking inside the stomach and assessing the mucosal disruption in all the gastric regions and even the first part of the duodenum. For foals, this requires a specific piece of equipment, a 1-meter-long endoscope with a maximal outer diameter of 9 millimeter. It's truly the gold standard.
That's impressive, getting an endoscope down there in such a small patient. And what about those specialized tests you mentioned earlier for delayed gastric emptying? Are they common?
They're more advanced, less common perhaps, but they include things like nuclear scintigraphy, the acetaminophen absorption test, and post-consumption 13C-octanoic acid, blood, or breath testing. When vets do find ulcers via scope, their characteristics can vary, from 2 millimeter to over 2 centimeters in diameter, often 1 2 millimeter deep, and usually surrounded by redness or hypererythemia. And it's worth hitting again that NSAID toxicity can cause ulcers in both glandular and non-glandular areas. It's not picky.
Okay. So once a diagnosis is confirmed, what are the goals of treatment? How do vets step towards healing these little guys and turning the tide in this hidden battle?
The two main goals are pretty straightforward: suppression or neutralization of gastric acid and supportive therapy. The good news is foals with mild to moderate ulcers should respond relatively quickly, typically within, say, 24 to 48 hours of starting treatment.
It's encouraging. So sometimes field treatment is okay, but when does a foal really need to be hospitalized?
Hospitalization is definitely recommended for foals showing more severe signs. Things like dehydration or electrolyte imbalances, suspected or confirmed peritonitis, any signs of sepsis, esophageal reflux, or just uncontrolled pain. For critically ill foals, supportive nursing care like IV fluids, maybe incortropic support to help the heart is vital to maintain perfusion and address shock, especially since, as we discussed, these contribute heavily to glandular ulcers.
And diet. Do they need special food or can they keep nursing?
A normal diet, usually nursing, is typically fine unless there's significant esophageal reflux. In those specific cases, parenteral nutrition, basically IV feeding, might be necessary for a bit.
Okay, circling back to that key insight we touched on earlier, if there's one single action an owner can take from this entire discussion, one game-changing insight, what is it?
It really is, again, to avoid the use of NSAIDs in foals without direct veterinary supervision, period. It's because of their well-known potential to cause gastric ulcers. This is something owners can directly control, and it's probably the primary lever they have to prevent this specific problem.
That's such a clear and powerful message. It really hammers home, doesn't it, how even treatments meant to help can have serious unintended consequences if not used carefully. What if medical therapy isn't enough, especially for those strictures you mentioned earlier? Are there other options?
Yeah, for severe gastroduodenal ulcer disease that leads to duodenal strictures, medical therapy might just not cut it. In those cases, surgical correction, like a pyloroplasty to widen the pylorus or other bypass techniques, may become necessary.
Right. Let's talk about the key medications then and their fascinating mechanisms. What are the mainstays of treatment?
Sure, there are several classes we rely on. First, histamine H2 receptor antagonists, or H2 blockers. You might recognize names like cimetidine, ranitidine, famotidine. They work by suppressing hydrochloric acid secretion. They competitively inhibit the histamine H2 receptor on the parietal cells in the stomach lining.
Okay. And then there are the proton pump inhibitors, the PPIs. They sound even more powerful.
They generally are more powerful and longer lasting. PPIs, like omeprazole, work by blocking the proton pump itself, the final step in acid production. This effectively suppresses acid secretion for up to 27 hours. They are very effective for treating gastric ulcers, and there are different doses recommended for active treatment versus prevention or prophylaxis.
What about simple antacids? The kind we might use ourselves for heartburn. Do they have a role?
Antacids, things like aluminum hydroxide, magnesium hydroxide, calcium carbonate, they do neutralize acid, yes. However, their efficacy for routine treatment in foals isn't really fully determined. The main issue is their short duration of action, which means you'd have to dose them very, very frequently to be effective.
Impractical, probably.
And often, yes.
And sucralfate, that one sounds a bit different. How does it work?
Sucralfate is quite interesting. It actually adheres to the ulcerated mucosa, the damaged lining, and forms a kind of protective proteinaceous barrier over the sore spot. It also seems to stimulate prostaglandin synthesis and mucus secretion, helping the natural defenses. It's best used as an adjunct, meaning alongside H2 antagonists or PPIs.
Okay, so an add-on therapy.
Exactly. And a crucial instruction for owners. Do not administer at the same time as other oral medications like Emprasol or H2 blockers. You need to separate administration by at least 2 hours because it can actually inhibit the absorption of those other drugs.
Oh, good to know about the timing. That's critical. Are there any other specific medications, particularly maybe for those NSAID-induced ulcers?
Yes, prostaglandin analogs like misoprostol. This is a synthetic PDE1 analog. PGE1, the natural version, inhibits hydrochloric acid and gastrin secretion. Importantly, it also increases gastric mucus formation and mucosal blood flow, which enhances protection. So it tackles both sides, reduces acid, and boosts defenses. This makes it particularly useful for ulcers induced by NSAIDs.
Makes sense. And finally, prokinetics. What are they for?
Prokinetics. A drug like bethanical, for example, may be given for duodenal ulcers, gastroesophageal reflux, and situations where delayed gastric emptying without a physical blockage is suspected. They basically work by increasing the rate of gastric emptying, helping move things along.
This raises an important point, though. Are there any contraindications or serious precautions people need to be aware of with these medications?
Absolutely. For instance, prokinetics like bethanical should not be used if mechanical obstruction, like a complete pyloric stricture, is suspected. Pushing against a blockage could worsen the condition or even lead to rupture.
That makes perfect sense.
Right. And precautions also include potential side effects. Misoprostol can sometimes cause abdominal pain or diarrhea. Bethanical can lead to diarrhea, inappetence, or colic signs. There are also possible drug interactions to consider. Cimetidine, for example, can affect the metabolism of other drugs, and bethanical should be used with other cholinergic agents. So the vet needs the full picture.
That's a lot to consider for treatment. Okay, so once a foal is being treated, how do vets monitor their progress? And what's the sort of long-term outlook for these vulnerable patients?
Yeah, patient monitoring is key. Ideally, a recheck gastroscopy is recommended about 14 to 28 days after starting treatment to confirm that the ulcers are healing. If gastroscopy isn't readily available or feasible, then improvement in clinical science becomes the guide. You'd expect colic diarrhea to usually resolve within 48 hours, and appetite, body condition, and general attitude typically improve within 1 to 3 weeks.
Okay, so what about prevention? Is prophylactic anti-ulcer therapy, like giving meds just in case, common?
It is routinely administered in many critically ill foals, yes, but this practice is actually quite controversial among specialists.
Oh, why is that?
Well, a couple of reasons. Some critically ill foals can actually have a predominantly alkaline gastric pH, meaning not very acidic. And some acidity might actually be protective against bacterial translocation bacteria moving where they shouldn't in newborns. Plus, prophylactic therapy itself has been associated with causing diarrhea in some neonatal foals. So it's a bit of a nuanced discussion weighing risks and benefits.
Interesting. So not always straightforward.
Not always.
Mm.
But the most crucial takeaway for prevention, which we've hit on a few times now, remains avoid unnecessary NSAID use in foals. That's the big one.
Got it. Are there any potential complications vets worry about even with treatment? And what's the overall prognosis for foals diagnosed with these ulcers?
Yes, unfortunately, complications can still occur. They can include developing a pyloric stricture, having acute hemorrhage from the ulcers, and the most severe, gastric or duodenal rupture, which leads to peritonitis and is very often fatal. The overall prognosis is quite variable. Foals, whose ulcers respond favorably to therapy for whatever primary problem they had, generally have a good prognosis. The ulcers themselves often heal in 2 to 3 weeks.
That's good.
However, foals with duodenal ulcers tend to have a more guarded prognosis. Their pathogenesis is more complex, and there's that higher risk of stricture formation. And as we mentioned, foals with perforating ulcers, unfortunately, have a grave prognosis. Our sources report mortality from gastric ulceration in foals ranges somewhere between about 7% and 16%.
Wow. So definitely serious, but with potential for good outcomes if caught and managed appropriately, especially for the more common types. We've just navigated the really intricate world of neonatal equine gastric ulcers, from the fundamental imbalance that causes them to the surprisingly varied ways they present, and the pretty sophisticated diagnostic and treatment options available.
Yeah, I think understanding the distinct types of ulcers, their specific causes, especially that impact of blood flow and, of course, NSAIDs and the very different clinical syndromes, is truly key to appreciating this complex condition and, facing that hidden battle effectively.
So what is this discussion room for you, the listener? It's, I think, a powerful reminder that even in the most vulnerable among us, like a newborn foal, there are these hidden battles taking place, battles that require an incredible depth of knowledge and really precise care. It also makes you wonder, doesn't it? What other silent conditions might be at play, just below the surface, waiting for a deep exploration, a deep dive like this, to uncover their secrets? We hope this deep dive has given you a robust foundation. Keep that curiosity sparked and continue exploring the fascinating intersections of biology and health.